Okay, perfect. Hi, everyone. Thank you for joining us at AVAC for our third cervical cancer awareness webinar. Today, we are really focused on cervical cancer screening and treatment. This morning, our speakers include Fred Wyand from American Sexual Health Association and the National Cervical Cancer Coalition, and Dr. Bothwell Guzha from the University of Zimbabwe. Both of our presenters will go through their presentations, and at the end, we will have a global Q&A session. So if you have any questions throughout these presentations, please feel free to put them in the Q&A box or in the chat, and we will answer those at the end of the session. Additionally, the session will be recorded and uploaded onto the AVAC website with PDF copies of our speaker slides. And with that, I turn our presentation over to Fred, and you will find his bio in the chat.
All right, thank you. Okay, well, I hope you can see my slides okay. Well, good morning, everybody. Thank you for letting me spend some time with you. I am indeed Fred Wyand, and I'm going to talk with you today about how we do communications around cervical cancer. It's not just what we say, of course, but it's also about how we say it, how we find our advocacy voice. And I'll try and sort of impart a little bit of the flavor of how we handle all of that. I don't have any disclosures. I'm always jealous of people who do. I have disclosure envy, but I don't have any today. Okay, so my parent organization is ASHA, the American Sexual Health Association. They've been around for a long time. They were founded in 1914, and for the last 25 years, ASHA has had cervical cancer prevention resource centers of some type. And I've been most of my career at ASHA, which is coming up on 27 years, has actually been working with these programs. About 12 years ago, we absorbed the National Cervical Cancer Coalition, and that's a really cool grassroots organization. Their founders decided to retire. They asked, "Man, do you you want us to park this program with you?" And we said yes. And NCCC really is a network of chapters. We have about 45, I think, across the country. And chapter leaders are basically cervical cancer survivors or patients or a family member who's lost someone to the disease. So we really work across the continuum from prevention all the way through diagnosis and survivorship. I'm going to talk with you a little bit now. This is where, we always say that this stuff is as much art as it is science. And I'm not a clinician. I'm not a healthcare provider. My background is in counseling and writing. But if you're going to talk about cervical cancer, you really have to talk about the virus that causes virtually every case of cervical cancer, HPV, the human papilloma virus. There are many, many types of HPV, well over 100 genotypes, and HPV infections can be found really in all over the body. But there are a few types that are linked primarily with sexual transmission and anogenital skin, and of course, those are the ones that we talk about. These HPV types include low-risk types, which really you think of primarily as genital warts. They don't have a lot of oncogenic potential, but also high-risk types, and those are the ones that you link with cancers of the cervix as well as a number of others that you can see there, even a subset of some head and neck tumors, and that's really an emerging area. We haven't done as much work there, but increasingly it's clear that we have to. Here's the thing, though. Most cases of HPV don't have any obvious symptoms. They typically resolve spontaneously. I think like after about 24 months, about 90% of HPV infections are undetectable. So most of them, even the so-called high-risk types, tend not to be all that dangerous. But of course, it's not always that simple. Sometimes the infections persist, the abnormalities they can cause persist. So that's why it's so important that we have prevention tools like screening tests, okay? And of course, everybody knows about the Pap test. A sample is taken from the cervix, hopefully of the interior and exterior portions. You send it off to a lab, it's viewed under a microscope, and the idea there is to check for any cell changes, abnormal cells that could be suggestive of something that needs follow-up or maybe even treatment, okay? The shiny new kid on the block is HPV testing. And this is really cool and it's different. Whereas the pap test finds physical cell changes, an HPV test, that actually finds the genetic material of the virus itself. So literally it gives clinicians a great tool to stratify risk. They can identify if a patient has a high risk HPV infection. And more to the point, is specifically if it's one of the types that are especially aggressive, like HPV 16 and HPV 18. Those are two types that are found with about 70% of cervical cancers globally. So understanding whether or not these infections are present is a boon, of course, really understanding a patient's risk and how to manage it. So, but of course, all of these great changes bring about an extra layer of complexity. And so the annual PAP is out of here. Used to be simple, right? Your cervical cancer screening was you get a PAP test, you pretty much go every year. There you go. It's not that way anymore. So now screening intervals have been pushed out 3 to 5 years, depending on the exact approach. And this is sort of in process because the PAP hasn't gone away. Screening with PAPs can still be done. That's the acceptable approach. But even with that, you go every 3 years. If an HPV test is in the mix, either alone or with a PAP, you go every 5 years. So, and HPV testing is really where the field is clearly moving, but the PAP is still hanging in there. So as you have these changes, we get a lot of questions and feedback. People call us, they send us emails, they go on our message boards. And the idea that the PAP, that you're not doing an annual screening or that you've got a new test is a source of anxiety or at least confusion also for some people. There's a thinking that, well, something has been taken away. I used to get an annual test. Now I'm not. Why am I being screened or tested less? I've lost something, right? Because more is always better. And we also have some concerns that, well, this is just a cost-saving move. I had somebody tell me directly, I don't want a bean counter telling me how often I can go have my cervical cancer screening, right? So how do we respond to that? We try and kind of shift the perspective a little bit. For example, we'll say, screening technology has really improved a lot. I mean, even the PAP itself, the way they're processed, they've evolved over time. There's not the same as it was 30 or 40 years ago. Even PAPs are better. And of course, now you have the HPV test, which bestows all the benefits that I was talking about. So it kind of makes sense that as our ability to screen has improved and evolved, the guidelines around how we use those tools are also going to evolve. And the thing is, too, the cervical cancer tends to take many years to develop. There's a continuum from HPV infection through the various precancerous lesions up until cancer itself. So the extended intervals really do give excellent protection. They really bestow all the benefits. But by not screening quite so often, you avoid some of the harms of overscreening. Um, you know, Sometimes, doing more testing I mean, it's not necessarily a benign thing, right? Because as we talked about, a lot of HPV infections are transient, and the abnormalities that come up with them tend to be transient as well in many cases. So by screening literally every year, you're going to pick up a lot of incident and transient infections and abnormalities that really don't require, a lot of aggressive treatment. But when we find things, the tendency, coming from a good place is to get in there and do something about it. So you tend to have a lot of referrals to biopsies and unnecessary excisional procedures that obviously are best avoided if that's okay. And in addition to that, there's anybody who's been through these can surely attest better than I can. They're inconvenient, they're stressful, so that's why as we have these better tools, you can get really the same protection by extending these intervals and avoid some of the harms of screening too much. The other bright shiny tool we've got that's come on, and I've been at this so long that I actually started before anything like the vaccine was available. But HPV vaccination is a great tool. It's approved to prevent cervical and a host of other cancers, including the head and neck cancers that I mentioned. It's available for everybody. It doesn't matter about gender. Anybody can have it. It's recommended routinely at ages 11 and 12, but it can be given as early as age 9. And that's really where stakeholders are kind of putting a lot of emphasis on getting that early vaccination in. But sometimes parents are not always so keen on that, or they don't really understand why. They're like, why does my 10-year-old need an HPV vaccine? They're not sexually active, right? Well, the thing is that may be true, but the idea is to get the protection in place before they become sexually active. They may not be sexually active now, but as they move through the teen years, they become a young adult, they probably will be. And sometimes this happens a little sooner than, parents are kind of aware of, So the idea is getting the protection in place before the onset of sexual activity. The other benefit to vaccinating younger is that you tend to get a more robust immune response, so much so that if you're vaccinating before age 15, you only need 2 doses instead of the standard 3. So there's a benefit there. All right. Um, I'm going to shift a little bit now. For every conversation we have on the clinical stuff and diagnostics and treatment, we have even more on the emotional relationship aspects. And this is kind of where I do my thing. This is where I spend most of my time interacting with people. There are a lot of psychosocial issues that come up with any kind of diagnosis here, from HPV all the way through cancer. And one of them is just the sense of I've done something wrong. I mean, I'll talk with people who'll go, "Oh, I can't believe it. I'm so stupid. I let my guard down. How could I let this happen?" That kind of thing. A lot of self-blaming and self-shaming go into this. There's a presumed loss of sexual freedom. I'm typhoid Mary. Who will want me? That kind of thing. So we spend a lot of time trying to kind of sort this, sort these kinds of things out. And how do we do that? Well, for one thing, we always try and normalize when we're talking about HPV infections. And I'll show you a slide next that kind of you can see how we do that. HPV infections are almost ubiquitous among sexually active people. Just about everybody has it at some point. And getting that perspective across, because a lot of people will tell us, I'm the only person I know who's ever had this. I feel like I'm alone. I'm on an island, that kind of thing. So helping them understand that's really not the case is a big piece of it. Using those facts and that data are great, and we really rely on that. But we also pull on the experiences here, like of our chapter leaders within CCC. These are mentors. They're either going through it or they have gone through and they've survived, and they can really help people who are starting this journey themselves to understand. Look, this is what to expect. This is maybe here's how I coped with it, that kind of thing. They are the most authentic voices we have, certainly more so than mine, and so we have a lot of things like videos and fact sheets and podcasts with these folks where they really tell their story, just so we can share that with people who are newly diagnosed, so they can kind of understand the path that they're on. And that fits into empowering with action steps. We really like to give people tools as much as we can. Here's a tweet I did talking about how we normalize things. One of my favorite lines is, "Do you know what it means if you have HPV? It means you're normal. You're human. The only difference between you and the rest of humanity is pretty much that you've got a diagnosis in hand." And the estimates are that something like 75 to 80% of all sexually active people have at least one HPV infection at some point. And some of our advisors actually say they think, if anything, those numbers might be conservative. So the point is, this is incredibly common. It's just a marker for having sex. It does mean that you're normal. Um, this was a tweet. This just sort of to emphasize the idea of shame and stigma. This came from Australia. One of their cancer foundations did a survey where 80% of the respondents said that they believe that regular cervical cancer screening is important, but 1 in 4 had acknowledged that they either canceled or delayed or just for whatever reason didn't go for their exam, simply due to embarrassment and lack of comfort with the procedure. So that's why it's so important to really help people understand what's happening, and that they aren't the only ones. Tools, always about offering tools, empowering people as best we can. We put together fact sheets like, can my partner and I pass HPV back and forth? Does this mean my partner cheated on me? The answer there is you cannot use a new HPV diagnosis to really determine whether or not somebody's been unfaithful. This is so common, but having those tools in place, these are the kinds of questions that people ask us. So we always like to get the messaging out and give them a tool they can go to. All right. I didn't really mean for you to read this big chunk of text. This is a screenshot from our website. The reason I put this here is just as we have a section for treatment, a section for vaccines, one for screening tests, we also have one for relationships and interpersonal issues, because we don't think that should be subjugated to these other topics. That is a frontline headline menu item in its own right. Here are some more tweets. I'll just call your attention to the one bottom left. We recognize March as Sexual Pleasure Month. And as part of that, I wanted to make the connection that, just because somebody has a cancer diagnosis doesn't mean that they should necessarily give up or that they want to give up on sexual pleasure. It's for everybody. And that's an important thing. On this slide, we did a survey a few years ago with cervical cancer patients and survivors about sex and intimacy. And it may be a little hard to see with that bar in the middle. 91% of the respondents said that they've had some issue with sex or intimacy as a result of their diagnosis. And when we ask them, well, is it physical? Is it emotional? 3/4 said it was both, so this is really an issue. And if you look at the last bullet point, a majority of people have not had really, helpful conversations with their healthcare provider about this. So this is a theme that keeps coming up over and over. And along with an infographic like this on our social media, we really, here again, give people tools. Here's a collection of resources. Here's a support group. Again, find a community so you're not alone, that kind of thing. Here's how to find a provider who can maybe help you work through these issues. Here's a tool to help you understand what to expect as a result of whatever treatment modality that's being used with you. Here's some tips, just giving people as many resources, as many connections as we can. All right. Last thing I'm going to talk with you about is, we sometimes we're very clinical, I think, in our approach, and we want to mix it up a little bit to maybe make things I don't want to say fun, but just to bring sort of a little bit of an edge to it. That helps. I think that helps us connect with people sometime. So, for example, on the left there, February is National Condom Month, and we did it. This is something I did where I was talking about the value of condoms in reducing HPV infections. So, try to get an image that's just a little bit more than something that you would see something in the school photo or something like that. On the right, we were doing a push for our January Cervical Health Awareness Month stuff. These are some of our chapter leaders. I corralled them at a conference and said, look, let's get together and take a group photo, but don't just stand there again like a school photo, show some attitude. And of course, they were only too happy to comply with that. And so just adding a little bit of fun into the mix, I think sometimes kind of helps us get our message across and maybe draw some more people in. All right, I feel like I just raced through these. I'm sorry. I get rolling. I get excited. I can't help it. Here I am. So if beyond our conversation today, you've got a question for me, you've got some feedback for me, you think you saw something there, and hey, maybe you want to add this to the mix, I would love to hear from you. Please feel free to reach out. Check out our websites there at the bottom where it says retention in the middle. I have literally no idea what that is, so don't pay any attention to that. But you can see the top two. That's our main national website and our NCCC portal, where you can access just a ton of stuff: videos, fact sheets, podcasts, downloads, posters, samples, social media, toolkits, just on and on and on and on. So thank you so much. I'm going to stop sharing now, and I'm really happy to be here.
Thank you so much, Fred. That was an incredible presentation. And I know I took away a lot about communication and the importance of communication when we're talking about cervical cancer and screening and HPV vaccination. So I appreciate it. And with this, we now turn our presentation over to Dr. Bothwell Guzha from the University of Zimbabwe. I will put his bio in the chat. And remember, if you have questions, please put them in the Q&A session or chat box. Dr. Guzha, we cannot hear you if you're speaking.
Okay, my apologies. My phone was mute. Thank you very much for the kind invitation to do this talk. I'm going to be talking about cervical precancer treatment, and I'm just going to I've got a couple of slides where I'm going to touch on disparities in invasive cancer treatment between low and high income countries. I have no disclosures to make, and this is the outline of my talk. So I think this has been said over and over again that cervical cancer is a global public health problem, especially in low and middle income countries. In 2020, there were 600,000 new cases of cervical cancer and about 350,000 deaths. About 90% of these cases and deaths occurred in low and middle income countries. But I mean, the sad thing is that cervical cancer morbidity and mortality is completely preventable. It has been shown that there's been a reduction in cervical cancer incidence and mortality, and this has mostly been observed in countries with a high human development index. But however, in this part of the world, I'm in Africa where I'm working in Zimbabwe, we still have a high burden and high mortality from this disease. So this is just GlobalCan data, just showing the age standardized incidence rates of cervical cancer across the world. And you can see that I just put a picture of Africa there, and right at the bottom is sub-Saharan Africa. And we lie in the eye of a storm where we've got such a high burden of HIV and a high burden of cervical cancer. In sub-Saharan Africa, Zimbabwe is the highest age standardized incidence rates of about 215 per 100,000. You can juxtapose these maps together because you see that in those countries where there's a high incidence, the mortality is also very, very high. Zimbabwe has got a mortality of about 145 per 100,000 women from cervical cancer. I've just included this data from the Zimbabwe Cancer Registry, which hasn't changed for many years. Cervical cancer is the commonest cancer in Zimbabwe in both men and women, and it is the single commonest cause of cancer deaths in Zimbabwe. So cervical cancer is really a big, the burden is still very high in low and middle income countries. So WHO has come up with a plan to eliminate cervical cancer as a public health problem. So there are 3 lines there on this graph. If you look at the gray line, it's just showing you what will happen if we continue with what's happening now at this moment. But WHO has suggested a way forward where you get 90% of girls being vaccinated against HPV, and you get 70% of women being screened with HPV tests at least twice in their lifetime by the age of 35 and 45, and 90% of women with pre-cancer and cancer getting optimum treatment. If you look at the blue line, if the whole world changes just to start vaccinating all the eligible girls, we will be able to eliminate cervical cancer as a public health problem by the year 2120. But however, if we combine intensive screening and vaccination, then we should be able to eliminate cervical cancer as a public health problem by 2090. So this is what is commonly being referred as the 90-70-90 initiative from WHO. Elimination via prevention through vaccination, screening and treatment of precancerous lesions, which is going to be my main talk today. I'm going to talk about the treatment because I think screening has already been talked about, and timely treatment and palliative care for women with invasive cancer. So these are the WHO recommendations now. Unfortunately, a lot of low and middle income countries are using visual inspection methods to screen women for cervical cancer. Why are they using visual inspection methods? It's because it's very expensive to set up cytology screening in terms of both material and human resources. But basically, WHO now recommends that women be screened with an HPV test starting from the age of 30, and they can be screened and treated on the same day, or they can be screened and having a triaging test and then treatment on a different day. Women that are HPV negative are recommended to be followed up in 5 to 10 years. However, for women living with HIV, the WHO still recommends screen, triage, and treat, and not screen and treat. So screenings will start at the age of 25, and HPV DNA will be used as the primary screening test, and these women will be screened every 3 to 5 years. And I know there's a bit of difference with the way that screening is done in the US and in some other European countries, but this is what a lot of low and middle income countries are adapting from WHO in terms of their screening. But the question that we have to ask ourselves is, with all this screening that has been happening, are these women who are screen positive actually getting treated? I was tasked with the Ministry of Health in Zimbabwe to do a midterm review of our Zimbabwe cervical cancer screening program. So at the baseline, when they started collecting the data in around 2016, 53% of women were actually were screen positive, were actually getting treated. That means 47%, almost 50%, were screen positive and never got any treatment. And the Ministry of Health had set a target for 2020 that 80% of women who were screen positive were meant to receive timely treatment. When we did the midterm review of the program, we found that only 66% of women who were screen positive were actually getting their treatment. That means a third of women who potentially had a lesion on their cervix went home and never came back to the hospital to get treated. So to reduce the incidence of cervical cancer, it's important that we get all women that are treated. We acknowledge that 66% is an achievement if you compare to other countries in our region, but it's still a long way to go. And one of the things that we've always been asking ourselves is whether we are really treating women with HIV. We know that there are challenges with visual inspection. For example, only 10 up to 20% of patients with a positive visual inspection test actually have abnormal cells on the cervix that warrant treatment. And also, we are not seeing women coming with early stages when I'm sitting in the gynecology clinic at the main hospital. So there is some screening that is happening, but some of the women are not getting treatment, and something needs to change so that we increase the number of women getting treated in most low and middle income countries. So if you are found to have a positive screening test, what are the treatment modalities available? So normally we divide them into two. One, excisional, where there's kind of like a removal of that part of the cervix, which is harboring the abnormal cells. Or you can have some ablative techniques where you try and destroy the abnormal cells, either using heat or trying to freeze them. So I think one of the commonest methods of removing these abnormal cells is a loop electrosurgical excision procedure, also known as a large loop excision of the transformation zone, and it's now called type 1 and type 2 excision. So since the early 1990s, LEEP has been widely used for treatment of women with abnormal cells because it allows for histological diagnosis, which allows for audit of colposcopic diagnosis, and this can be performed in the office under a local anesthetic. But however, there's been a lot of challenge that we face in the low and middle income countries with this procedure. One of the issues is costs. So for you to be able to set up, you need to be able to set up a colposcopy unit where you need a colposcopy machine, you need an electrosurgical unit, you need to buy the consumables for doing the LEEP, and the patient needs to pay for the histology after the LEEP has been done. I've already mentioned equipment, and one of the major stumbling blocks has been that this procedure can only be done by trained personnel, and in the case of Zimbabwe, nurses are not allowed to do it, and it can only be done by trained doctors. So with such a huge shortage of doctors, it's something that has been very difficult to implement, and it has not been commonly used in a lot of low and middle income countries. The other type of excision that can be done on the cervix is what is called a cone biopsy or a type 3 excision. These are women where you see that there's a lesion on the cervix, but you can't see the whole extent of the lesion. So some of the lesion is hidden within the endocervical canal.
Alert from calendar.
We also do this procedure if there's a discrepancy between cytology and colposcopy results, because we've got a very high loss to follow-up rate. So if a woman comes with a HSIL pap smear and the colposcopy doesn't seem to find a lesion, we recommend doing an excisional procedure rather than a biopsy, because that woman might not come back, but there might be a high-grade lesion that has been missed by colposcopy. We also do this procedure in women where there's been suspicion of microinvasion or where there are endocervical cell abnormalities. The cold cone biopsy can be done using the cold knife, it can be done using the hot loop, or it can be done using laser. But what is commonly available is the hot loop, which can be done in the clinic, or the cold knife. But there are challenges as well with this procedure. You need trained personnel to be able to do these cone biopsies. There's an issue of cost. There's an availability of theater or operating room time. And in a cone biopsy, are removing more tissue from the cervix. So there is a higher risk of adverse obstetric outcomes. So a lot of movement has been made to go to ablative treatments. And one of the most common ablative methods for treatment has been cryotherapy. So cryotherapy basically means you are freezing the cervix. And it was the most widely used ablative method, probably still mostly widely used ablative method in the world. It is very safe and acceptable. It has got cure rates of around 90% when the abnormal cells are confined to the visible part of the cervix. However, there are some challenges that we face in low and middle income countries. This procedure requires uninterrupted supply of refrigerant gases such as nitric oxide or medical quality carbon dioxide. And these supplies are erratic and might be difficult to find. The refrigerant gas may be expensive or not available in certain countries, and this is the case in a lot of sub-Saharan African countries. And because this gas is contained in a huge tank, it's very difficult to carry around the tank with you if you want to do some outreach programs in hard-to-reach areas. So it's very, very difficult to do these outreach programs if you're using cryotherapy as a modality of treatment. And Zimbabwe is currently transitioning towards thermal ablation, so as many other low and middle income countries. So thermal ablation basically means that you are treating the cervix with heat instead of freezing it. It has been shown that it's a feasible alternative to cryotherapy, as it uses lightweight portable electrical generators. Normally, there's no anesthesia that is recommended, and the duration for applying the thermal ablator is 20 to 45 seconds, and the cervix is heated up to 100 degrees. Studies have shown an overall cure rate of around 94%, with a confidence interval for about 91 to 96%. There are a few reports of women discontinuing this procedure due to pain, but a lot of times this procedure is done without any local anesthetic, and most women tolerate it very well. However, there was a study that was done in India which showed that about 61% of women treated with thermal ablation without any local anesthetic complained of some pain, but in the majority of cases, there was only mild pain, and less than 2% of these women actually had severe pain. So at this moment, I'm currently involved in a study which I'm doing in collaboration with international agents for research on cancer. There's not good enough data to show the optimum duration for treatment with thermal ablation. Some units apply this for 20, some for 30, some for 35, or some for 45 seconds. So we are randomizing women into either treatment for 20 or 30 seconds, and we're also randomizing them into treatment with or without analgesia, because we find that there's a bit of a conflicting evidence if you look at the data across the world. We have had a problem that our recruitment has been very slow, and we are finding that a lot of patients who are positive on AVAC actually don't have any disease on colposcopy. So, I mean, this is just to highlight some of the challenges that we experience with visual inspection. I'll move on to cervical cancer treatment. So once you have been diagnosed with cervical cancer treatment, your treatment depends on the stage, development, on how fit you are, what you normally call the performance status, and the fertility wishes of the patient. So the modalities can be either an operation, surgical, or a using of X-rays or radiation therapy, or it can be a combination of these treatments. So you can, if the disease is early and the woman wishes to preserve her fertility, the tissue can be removed from the cervix, either through a cone biopsy, or you can just remove the cervix, what is called a trachelectomy, and so that the woman keeps the uterus for future fertility. In patients that have got slightly advanced disease, but which is still operable, the operation of choice can either be, if it's very small, can be as simple as hysterectomy and removal of pelvic lymph nodes. BPLN stands for bilateral pelvic lymph node dissection, or doing a radical hysterectomy if they've got a tumor that is between 2 and 4 centimeters. And in women that have got advanced disease, they might be treated with a combination of radiotherapy and chemotherapy. However, there are huge disparities in the care of women with cancer if you compare to high-income countries like the US and low-income countries where we are actually working. So staging for women with cancer requires some advanced imaging. Advanced imaging has been shown to be way more superior compared to clinical examination or doing simple imaging like chest X-ray, abdominal and pelvic ultrasound. So we find that in most low and middle-income countries, they have no access to a CT, they have no access to an MRI scan, or they have no access to more advanced scans like PET scans. So basically, staging is still primarily being clinical based on examination in the clinic with very limited examination investigations consisting of a chest X-ray, abdominal and pelvic ultrasound. So this staging might be less accurate because sometimes it's not possible to pick up lymph nodes on doing the ultrasound scan. There's also challenges with the resources and trained personnel for surgery. For example, Zimbabwe has got a population of about 16 million, but there are only 2 gynecological oncologists. At the moment, I'm the only one who's still working on the ground because the other gynecologist has moved on to the United States of America, where he's now primarily based. And for the past 1.5 years, the majority of women with cancer, they present with more than 2B disease, where they need a combination of chemotherapy and radiation. In Zimbabwe, there's not yet that treatment available. The machines have broken down for the past 1.5 years. So sometimes we have resorted to giving neoadjuvant chemotherapy or chemotherapy to try and make the cancer smaller, and then we operate, but this might have inferior oncological outcomes compared to the standard of care, which is chemotherapy and radiation. So at this moment, I've just touched on prophylactic vaccines. There are vaccines that have been shown that they prevent rather than treat the HPV infection. But however, there's a study that is undergoing at this moment under the AIDS Malignancy Consortium, where we are doing when we are doing a leap on women and at the same time vaccinating them to see whether it will reduce the risk of having a residual disease or a recurrent disease. And there's been a lot of work being done on therapeutic HPV vaccines that will be able to actually clear the HPV infection. And a lot of studies have actually shown a trend towards efficacy for treating patients with CIN. However, one of the challenges that we foresee is that most of these trials don't include women living with HIV. And the Bill and Melinda Gates Foundation at this moment is doing a lot of modeling work that I'm involved in to try and design what would be an ideal vaccine and assess the best model to deploy it. So this kind of like one for the future, if we're able to get a therapeutic vaccine to help women clear the HPV infection. This is just a list of some of the studies that have been done on therapeutic vaccines. And at this moment, we are also involved in some cascade trials network where we are actually looking at a number of research questions. For example, we are looking at women with HPV positive, treating if they don't have HPV 16 or 18, we just treat them regardless even if their visual inspection is normal, or comparing to women that we follow up instead of treating to see whether treatment helps with clearance of the virus and reducing the incidence of CIN2-3. We are also looking at use of different probes, using an extended probe that gets into the endocervix or flat probes to see which one would be better in terms of treatment outcomes, as well as to compare treatment outcomes of thermoablation versus excisional procedure. So in conclusion, I would like to say most low and middle income countries to employ the screen and treat method. So we try and treat most women on the same day so that we minimize loss to follow up. But there's some recent data showing high failure rates in using thermoablation in women living with HIV. So I think in conclusion, more studies will be needed to determine optimal treatment, especially in women living with HIV. These are some of my references, and thank you very much for taking your time to listen to my talk.
Thank you so much, Dr. Guzha, for that talk. I think that it was incredibly helpful, and your inclusion of women living with HIV at the end was so helpful in better understanding how cervical cancer can impact different populations. And so with that, we are going to have a Q&A session. And so, Dr. Guzha, thank you. You're no longer sharing your screen. So we had one question in our Q&A, and everyone else, please feel free to add in more. So we had Julie ask, once someone has had cancer or pre-cancer from HPV, is that enough justification to change the screening timeline of once every 5 years to more frequently?
My co-presenter can probably address that better than I can. I'll just quickly say before deferring to him that sure, I mean, there are algorithms about how to manage abnormal or positive screening tests. And of course, you know, it's very personalized. It depends not only on the extent of the abnormality or an HPV status, but also things like a person's age can and their pregnancy status, I think, can influence that as well. So yeah, obviously, if something is detected that clearly requires management, there will be more frequent follow-up and engagement, but I'll defer to my co-panelist on that. He's the expert.
Yes, so that's apparently that's very true. So once you've been you've been diagnosed with a high-risk HPV, you actually need more frequent follow-up until you clear that that HPV. So it also it depends on whether at colposcopy some abnormal cells have been found, but normally it's kind of like yearly follow-up until you clear the HPV. And then at some point, you then go back to routine screening. So yes, when you've got an HPV infection, you need a closer follow-up.
And so for those who might have limited access to a clinician or to HPV testing and screening services and treatment services, you know, what are some of the options for them once they have either had an HPV infection or once they experience some of these cancers and precancers? Do you have any advice in those situations?
So what I would say is that in most low and middle income countries, HPV is not yet widely available. I think a lot of countries are at the moment transitioning to HPV. So at this moment, the commonest modality for screening women in low and middle income countries is actually visual inspection, where you put some acetic acid, you put a speculum, put some acetic acid on the cervix, and either you look at it with your naked eye to see some white changes, or you can use some form of an image to see where the abnormality is. So we employ what is called screen and treat. So once something abnormal is seen on your cervix, you get treatment on the same day if you so wish. And because of the challenge that I've mentioned with a lip or a excision procedure, most of these women are treated with thermoablation on the same day and they go home. And normally we follow them up every year just to repeat the visual inspection. And if they're HIV infected, actually the current guidelines still recommend yearly follow-up. That is going to change very soon. But if they're HIV uninfected and if they come back after treatment, and the visual inspection is now normal, they are followed up after 3 years. So we don't have ready access to HPV, so we still rely on visual inspection in Zimbabwe and most other low income countries. Pap smears are very expensive to set up. They are not readily available except in private practice in most low and middle income countries, unlike in the US and other high income countries.
Thank you. And so recently there has been a lot of news attention around a study that found that women who had received the HPV vaccine within their teenage years did not have any cervical cancer. They found that there were no cervical cancer cases among this age group or this population. And so thinking about screening and treatment services when we have such an effective vaccine, how do we still I think communicate the importance of screening and treatment even once you've been vaccinated?
Well, I think that gets to the point of as our tools are evolving, of course, our thinking about screening and intervals and how we go about it changes too. I mean, that's a great question. Screening, I can't predict how it's gonna, when you have a more fully vaccinated population, I'm not sure what exact effect it'll be, but I mean, it still makes sense, I would think, to get screening because as I understand it, the vaccine that's currently marked in the US, for example, it covers the HPV types that are found with about 90% of cervical cancers, but it doesn't, it doesn't literally cover every single type that could cause cervical cancer. It's amazingly effective, but screening is, I don't see screening going away anytime soon. It may change over time, but it's not just as it has been evolving, but I don't see it going away. And there are probably other reasons. I mean, for that exam, there are other reasons to check in and have those exams besides screening. Again, I'll defer to my panels on that who actually takes care of patients, but I don't think it's going to go away anytime soon.
Dr. Guzha, did you have any other thoughts?
So I totally agree with what has been said that a vaccine, it depends on the type of vaccine that you get. There are some vaccines like the Cervical Guzha that only offers 70% protection, and Guzha offers 90% protection. So it's not 100% protection. And you're going to find out, so the uptake, even in high-income countries, in some countries is not very high due to various reasons. So some people, women, or some people object to it on religious grounds, or for other different reasons. Some people would think that it will poison them. Some they reject it on religious grounds. Some they reject it because they think that it will kind of like promote promiscuity in girls. So we find that even if the vaccine is not available, a quite significant number in the population of women will not get the vaccine. So I think because of that reason, I think screening will be with us for quite some for the foreseeable future.
And now we have another question in the Q&A box. And so we have another guest who says that they've come across patients in their 50s that had HPV vaccination 20 or so years ago, but still experience cervical cancer. Am I right to assume the vaccine has gotten more effective?
I think the vaccine is effective, but I think like what you've just said, it's not 100% effective against all the high-risk HPV types. So you can still get other types of HPV that can actually lead to cancer. That's why it's too. I think we're still sifting through the data, and obviously the guidelines might change sometime in the future about how we screen vaccinated populations. But I think in the meantime, the take-home message is that even if you are vaccinated, I think it's recommended to continue with screening.
And so we have another question of what are the key symptoms that show one is having cervical cancer? Your answer will help women that don't have access to primary health care. And so Dr. Guzha, I think that one's directed at you.
So the majority of women, Alison, we present with some form of intermenstrual bleeding. So I always tell women that if you find that you are bleeding outside your menstrual periods or you are bleeding after menopause, you have to be concerned. That should warrant you to visit your healthcare practitioner. These women also commonly experience bleeding during sex, so what you call contact bleeding, and also they start experiencing an offensive vaginal discharge. So if you've got a woman who's bleeding in between their periods, bleeding after sex, and now they have an offensive discharge, those are kind of like the symptoms that usually cause women to go to the hospital. If they delay coming to the hospital, then they are as the disease advances, they start having more significant symptoms. So, for example, if they start getting a lot of pain, it's a sign that this cancer is advanced. Cervical cancer can grow and invade the bladder or the rectum. So in Zimbabwe, we still see some women coming in, they are just leaking urine because the tumor is grown into the bladder. And some will come in, they are actually leaking stool through their vagina. I'm not so sure whether you still see that kind of disease pattern in the US, but here in low and middle income countries, we still see women presenting very, very late with those advanced symptoms. But a large majority of these women will come with intermenstrual bleeding, inoffensive discharge, bleeding after sex, and later on they will have pain and other symptoms if the diagnosis is delayed. But I think it's important to emphasize screening because in the early stages, cervical cancer can be asymptomatic. That's why it's very vital for all women to be screened.
Perfect. And then we have a question in the webinar chat. And so Helen has asked, the remnant testing for HPV, is that NAT or PCR?
Sorry, Alison, I didn't get the question.
The remnant testing for HPV, is that NAT or PCR?
Is it?
The testing, HPV testing, is it NAT or PCR?
I think it's, I'm not hearing the word before PCR.
NAT, N-A-A-T.
No, it's PCR.
Okay.
It's PCR. And I also forgot, I don't know whether this has been touched before. So I think one of the reasons why some women are not getting screened is that they were not comfortable coming to the doctor's office. Studies have now shown that women can actually take the swabs themselves at home and they don't have to, what we call HPV self-sampling. Studies have shown that collecting the swab, if a woman collects the swab herself, compared to someone who comes to have the swab collected by a clinician, the rate of detecting HPV is not different. So I think there is a lot of movement towards encouraging women to sample themselves. And I think that may be very, very useful in terms of if we have another pandemic like COVID, which results in reduction in screening rates, where I think these swabs can be mailed to women at home. They take the swabs and send them back by post so that women can continue getting screened. So there's been a lot of excitement, and we are doing a lot of work to try and see how we can upskill HPV self-sampling in our communities.
And then we have another question. So we had at your presentations that HPV vaccines for a certain age is 2 doses and for other ages is 3. Why the difference? And some countries are only giving 1 dose only. Please clarify.
Well, I think the main reason there is that the immune response when given at a younger age is simply more robust. You just get you get higher titer levels, higher antibody levels when you give it, especially in the preteen years. That's part of the reason why there's a push to really have the vaccine given as early as age 9, and it's approved for that. So that's why, yes, so starting at age 15 and up, that would be a 3-dose series, whereas below that you can do a 2-dose just because you get a more robust immune response. I know that the idea of a single dose is in play. That's definitely developing because there is some data. I apologize, I don't know it off the top of my head, but there is some data showing that there is a fair amount of protection conveyed with that. But currently, it's either 2 doses or 3 doses, depending on the age.
Perfect. And I will add to that, the WHO has some really great guidance on dosage and the 1-dose schedule and the benefits of that. We're hoping that with a 1-dose schedule, there will be more vaccines available for more people, really creating more supply so that more folks can get vaccinated and be protected against these HPV-related cancers. So the data so far has been really promising, and I think that there are still some questions out there on just how effective the 1-dose is. And we hope in the next few years to, I think, have more data and more information so that there will be more solid guidelines that are a little less confusing for folks. And so the last question for today, Fred and Dr. Guzha, what would be your last message to advocates about cervical cancer screening and treatment?
Well, for me, it would be just hitting that idea that HPV is normal, and that's just such an important thing. And we know that once people start embracing that concept, that helps. If there is some psychosocial distress, that helps cope with that. So that would be the big thing. And also just a sense stemming from that of community. We have, like I mentioned, we have message boards. That's basically a cervical cancer community where people, no matter where they are on their cervical cancer journey, they can check in and they realize they're not alone. That's just such a big piece of it. They get that support, and they can have mentors who have actually gone through this before, and they can share those experiences.
I, I think my take-home message, Alison, is that cervical cancer is a completely preventable disease. And I think all of us should embrace the WHO elimination plan by scaling up vaccination and screening with a high-performance test, and making sure that women that are screened positive, or those women with cancer, actually get optimum treatment. I think we should all embrace that and aim to give that as a gift to the future generations that we've managed to eliminate cervical cancer.
Well, thank you both so much for your presentations today and those last messages. I really appreciated both of your presentations and everything that you have taught me today, along with all of our attendees. And with this, our webinar is over. You will again be able to find recordings on our AVAC website, and that will be emailed to all of our attendees later. And I hope you guys have a great day. And with that, toodles.